Good afternoon all. I'm Dr. Nafis bin Jamayat. Now I will be giving a lecture on dental ceramics application in prosthodontics. In this topic, uh, we will select some of the keywords that we really need to understand first. First is ceramic. Second is dental. Third is prosthodontics. So, what is actually ceramic? So we can see an object of nice ceramic. So if you really want to call something ceramic, it should have three things. It should be inorganic, such as magnesium, aluminum trioxide, silica, some other inorganic compound. It should be non-metallic, and beneath the structure should be crystalline in nature. In 1800th century, a person called Bodger, he first time mixed gypsum with feldspar flux, or we call it feldspathic agent. Now, feldspar flux, the word feldspar actually is a German word. The fels means field. So some of the inorganic compound found in field, which actually is a rocky substance, by nature it is actually colorless, and it is gray. So it means that this rocky substance has a tendency of light pass through it, which actually known as translucency property. For aesthetic reason, this translucency property is very much needed or essential. So he mixed this feldspar with the gypsum product, and he created, or he proposed this one as a ceramic. That's how the ceramic has developed in long time back. Furthermore, among all varieties of ceramics, we know that glass ceramics are most popular and widely used. Even the glass ceramic is also widely used in dentistry also. So what is actually glass ceramic? As we have mentioned that it has to be inorganic, so mostly glass ceramic is made of silica and combination of silica quartz. And if you mix the feldspar, which is more composed of sodium and potassium, it gives a colorless translucence property to the glass ceramic. So it is actually called glass ceramic. So we have seen in the past, even in the world, various places, there are many museums as a collection of ceramic. If you look back to the history chart, we can see here from 200 AD towards 1800 AD, we can see the first porcelain was invented by Chinese population. Is called Chinese porcelain, something around in between 400 to 600 AD. Then European got this technology from China, and they developed the first European China ceramic. From that period of time, from 1200 till 1800, the dental porcelain, and by means of other porcelain which is used in plumbing, electrical, hardware, stoneware and artware, has been created or invented. So it came to the markets, right? So compared to all these ceramic, if we see their structure or compositions, we can see that this triangle give a very good explanation that it has a three arm, left arm, right arm, and the bottom arm. We can see that the dental ceramic, the yellow coated one among the other ceramic, has the more feldspar flux contained in combination of quartz and clay. Because as I have already mentioned, that feldspar is a colorless and gray material, it has a translucence property. So why ceramic? We know that we used a long time back, even now also, metal restorations, and it has an aesthetic concern. To improve the aesthetic demand, the ceramic has arrived. And also, in addition to that, it has several things, like it is excellent chemical durability, it has a good wear resistance, it's biocompatible, it's environment friendly, and the last one is the most important, it is aesthetics. So this is a classic difference between metal and ceramic. I will not go too long. Less plaque accumulation for all ceramics. It is translucent, has more tooth shades, aesthetics is better. So ceramic has two components. One is ceramic core, another is veneering the porcelain. So ceramic core actually made of three things. One is lithium disilicate, aluminum oxide, zirconium oxide. Veneering porcelain also the outer layer that we do, the outer layer layering, is made of fluoroapatite, aluminum oxide, and lucite. So let's go to the classification of dental ceramic. The classifications actually made of few things. First is the fusion temperature. Based on the fusion temperature, then based on the different types of applications, what are the procedures of fabrication techniques, the most importantly, the crystalline phase. We will emphasize more on this part, the crystalline phase. So according to the crystalline phase, the classification of dental ceramic based on this category is actually three subcategory. One is the glass ceramic, the second is alumina, the third is zirconia. So basically glass ceramic is a mix of silica and silica quartz, and when this silica quartz is actually mixed with feldspar flux or fresh batik agent, it actually come out as a glass ceramic particle. So it has different crystallization phase. At the initial stage of the crystallization phase, it is liquid. Then it has to be cooled down, then you have to give subsequent heat treatment. Then while you are giving a subsequent heat treatment, there are multi-phase solid structures being created. First is small crystal nucleus will form. This stage is called crystal nucleation, and followed by the crystal nucleations. When we have sufficient amount of crystal nucleations are there, they will start grow more to reach until the optimal growth level. So the second phase is called crystal growth. So the crystallization phase of glass ceramic has two phases. One is T1 and another is T2, whereas the T1 is the nucleation and T2 is the optimal growth of each crystal. It's called the growth, T2 factor. So this glass ceramic has two subtypes. One is lucite reinforced feldspar glass ceramic. So it is glass, silica and quartz mixed with feldspar, and it has lucite inside. The lucite has incorporated to this subtype because to raise the coefficient of thermal expansion. But literally this variety has lesser compressive and flexural strength. Therefore the system derived from this classification, which is known as IPS Empress, mostly used for single unit complete coverage restoration in the anterior segment. Posterior, it is not that recommended because of the strength issue. The second subtype is actually called lithium disilicate apatite glass ceramic. It is also another glass ceramic mix of feldspar oxide or flux, whereas in the total volume, they have 70% volume as the lithium disilicate. Now the structure of lithium disilicate, as you can see this picture, is very delicate. It has very small plate interlock with each other. Right. So what happens is that when there is a pressure or compressive or flexural pressure there, there is a cracked line to be created. But the crack will prevent in the interlock phase of these small delicate structures. So this is also called as a needle-like structure. So it has more flexural strength compared to the previous one, the lucite one. And the system derived from this classification known as IPS Empress 2. So IPS Empress 2 used for anterior area. Also we can use for like multi-unit restoration, 3-unit fixed partial denture prosthesis. So I again summarize between the lucite, that lucite has IPS Empress 1, but it has lesser compressive or flexural strength. Therefore, it is recommended for single unit or anterior restorations, whereas lithium disilicate, it has more compressive flexural strength due to its delicate structure inside it. The system derived from it, the IPS Empress 2, we can use for anterior single unit restorations. Also, we can use for multiple 3-unit fixed partial dental prosthesis option also. We have another version is known as IPS Emax Press from lithium disilicate, which is also commercially available at the market. The second one from the crystallization phase classification is the aluminum core system. It is again a mix of glass ceramic with the alumina. So you have silica quartz or other inorganic compound mixed with feldspar, and it has alumina core. Now, if you can see in this picture that inside the ceramic you have alumina core which can prevent the crack. It is a crack stopper. So it has in the market there are two systems actually available. One is the in-ceram alumina. The second one is the in-ceram spinel. In-ceram spinel has more magnesium content, so it is more translucent compared to ceram alumina. But whereas in-ceram spinel has less flexural strength compared to in-ceram alumina. So in-ceram alumina is used in single unit restoration, also 3-unit anterior restorations. In-ceram spinel only recommended for anterior crown. The second subtype under the alumina core system is the pure alumina. Here there is no glass substructure, there is no quartz, it's pure aluminum core is being used. It is superior in translucence. It has shown a greater strength compared to the previous IPS Impress 2 system. In the market there are two systems are available, the ProCeram, AllCeram and TechCeram. Since it has a greater translucency and it has a good strength, it is suggested to use for single crown or 3 to maximum 4-unit bridge in the anterior area. But even though it is mentioned that it has a greater strength, but it is not like zirconia. The zirconia, the third system, has the highest strength compared to the previously mentioned system because of its tetragonal particles. If you see in zirconia system in this image that it has inside the crystal looks like tetragonal particles. This is tetragonal in shape in the image. What happens when there is a pressure in zirconia structure, these tetragonal particles will start transforming into the monoclinic particles, and when the stress at its peak point, this transforming monoclinic particle will completely transform into the full and final monoclinic particle. Thus it prevent the through and through crack. That's why the zirconia system shows greater strength compared to other system that I mentioned before. Another thing for the zirconia is sometimes there is a material called yttria. Yttria stabilize zirconia. We have seen in different literature that yttria stabilized zirconia shows more transformation from the tetragonal particle to monoclinic particle, and it prevents more crack. It is called metastable tetragonal structure transforming into the monoclinic structure. And we have in the market lava, zircon, TCS President, Benzene. There are varieties of system of zirconia available. Because of these tetragonal particles and monoclinic particles, zirconia looks very trans-opaque compared to the previous systems. So let's look at back to the manufacturing technique. We have conventional heat pressing, slip cast and CAD/CAM technique. So conventional technique is pretty simple, that you have to mix fine powder and organic binder, then you have to mix, then you have to do you have to make a die, thermal pre-sintering, and you do the final sintering of the ceramic. So what is actually ceramic? Ceramic sintering. Ceramic sintering is during sintering a mass of individual particle loosely held together by water binder converts into the coherent solid. So different particles are together to make a solid mass by a heat treatment. There is a high temperature need to be introduced. This is called sintering of ceramic particle. Heat pressing is quite same as the fabrication procedure of cobalt chrome cast partial denture. You have to do the waxing, then we have to connect a sprue, we have to invest it, we have to burn it. Then from the burn channel we put the the ceramic material which is called a casting. Finally, we cut the sprue out and we do the polishing. Slip cast technique, we should have a working model. We have to block out the undercut. Then we have to apply a varnish, which is like a separating media. We have to duplicate, and after duplicating, we got another working model. Then we make the slip, and manually with the painting brush we apply. Then we have to do the fire, that is called baking. So we have to check the fitting onto the cast. Then we do the substructure after glass infiltrations, and we do the coloration and most outer layer veneering, and this is the final restoration drying in the model, and finally it will be introduced to the patient mouth. This is called slip cast technique. CAD/CAM technique, yes, we have many intraoral scanner in the clinic. We can do the, after doing the preparation, we have to do the intraoral scanning, then get the information into the computer. We design the prosthesis, something like this. Or you can make a cast and send to the scanning, and you get the negative imprint into the computer software. You do the design, and after that finally done design has to send through a signal through a milling process. This is called subtract technology, that will have a square block similar to the tooth color shape, and different color of shape blocks are available into the market, and the mill will slowly start cutting down that square shaped block into the final desired shape of the ceramic crown or the restorations. And sintering, we have to do the sintering followed by the previous technique, previous step, and we do the final veneering, the outer layer of the coloration. So this is a summarized table that I tried to summarize the different system, like just a refresh back what we have just discussed now. We have glass ceramic, lithium disilicate, lucite, feldspathic. So these are the name: IPS Impress 2 lithium disilicate. We have lucite, IPS Impress. We have feldspathic, Vitablocks, Vitatrulax, Vitablock aesthetic lines. How we process it, heat pressed and milled, and some indications, clinical indications why you use it. We have to keep remember there are certain factors need to be discussed, or among the technicians and dental surgeons before choosing the proper ceramic system for particular restorations. We have alumina. Under alumina we have alumina oxide. We have zirconia, as I have discussed. We have lava, zircon, denzite, procera, biocare. So this is a summarized table. We can look back later after the lecture. So we already know about the classifications and different types of ceramic, but the question is how we actually proceed to select prior a clinical case need to be performed. The three things to be considered: first thing is fitness, second thing is strength, and third thing is aesthetics of the ceramic system that we are going to select. So regarding fitness, all ceramic crown with smaller gap dimensions at the axial wall and marginal opening demonstrate the best compressive strength. So we have ADA specifications. For type 1 luting agent need minimum 25 micron, type 2 luting agents we need 40 micron. This is, I'm talking about the gap. And for the marginal and the internal fitting, clinical acceptable range of marginal gap is there's a range in between 100 to 150 micrometer. So this is a table from this literature. We can see that among all the system, the IPS Impress it has the highest internal gap, 206, but other one has within the limit within the limit between the 100 to 105, which is pretty much acceptable in the clinical practice. So we should take consideration of all these facts prior to choosing the proper ceramic system for our restoration. Second thing is the color and aesthetics. For color and aesthetics, the core translucency, it is actually primary factors for any aesthetics and color outcome result for any restoration. And among all the ceramic system that I have discussed until now, from translucency, highest to least actually showed the Inceram spinal has the highest translucency, followed by IPS Impress, Procera, IPS Impress 2, Inceram Alumina, and inceram zirconia. Now, we know that any color has a hue, chroma, and value, right? So, hue is the color, and chroma is actually the chromatin, how yellowish it is, right? So, more chroma means more yellowish, and value means high to low. If someone said that this color has a high value, actually it means that uh, it shows a greater light in front of you. If the color has a low value, that means that it has a lower light coming from that structure. So, in other words, if we try to understand that when we are driving in the road, if opposite direction a car is coming with a high light, we actually cannot see what is happening behind it. So we try to give them a signal to reduce the light. So this is the phenomenon that we have to understand in the clinical field. So when there is a greater light projecting, we can see the substructure beneath it. But when there is a low light value, we can see more substructure. So as if like these pictures, we can see that from left to right, the higher value to getting to be the more darker low light, it is called the lower value, right? So select a substrate material that closely resembles the natural translucency and grayness of the teeth. Let's say after we do the tooth preparations, if we see that the prepared tooth has a good amount of translucency but low value, a minimally colored translucent core material such as like Impress or Inceram Spinel or Impress 2 will be suggested. Whereas if a translucency comes with the average value after doing the preparations, we can also use the same, the color translucent core material like Ceram Spinel, Impress and Impress 2 we can be used. But if the value is higher, more light is coming from the tooth translucency, more opaque substructure like Inceram alumina or Inceram zirconia is suggested. So later on, the last factor is the compressive strength. We can see that among the all ceramic system, in all processing technique, the alumina has the highest flexural strength in megapixel. So this is one thing. Another thing is surface area of connector. It is taken into the consideration while fabricating the multi-unit restorations. The ceramic system, which has the less amount of flexural strength, such as Impress 2, 300 to 400 megapascal, it requires more connector surface area in order to get the more strength. Whereas if you see this table, the lava has got the highest flexural strength from 900 to 1200 megapascal. So it requires lesser amount of connector surface area such as 9 millimeter square. So this is one of the considerations that we have to take in while designing the connector size. So in conclusion, I would like to say that successful application of these materials will depend upon the clinician's ability to select the appropriate material and manufacturing technique and cementation of bonding procedures. So time to time we need to update. We need to update our knowledge by reading various kinds of research papers, try to understand their findings, their study outcome, and we have to use those informations into the clinical field. So our patient will get better service from us. So that's all about the lecture. Thank you very much. Thank you to all for your kind patience throughout the lecture. If you have any inquiry, if you want to know more details, you can contact me. Maybe we can sit together in the tutorial segment, tutorial lectures. We will discuss more small detail about the whole topic. Thank you all. Thank you very much.